Welcome, everybody. On behalf of everyone at the Center for Brain Health, welcome to the Frontiers of Brain Health, where we take a deep dive into the most exciting new developments in brain research. My name is Bart Ritma, and I'm a professor at University of Texas at Dallas and the director of the Brain Health Imaging Center right here in the Brain Performance Institute, and also director of the Neuropsychometric Research Lab here at the Center for Brain Health. So we'll have a few minutes at the end of Dr. Ekhtiari's talk to answer some questions. So for the virtual audience, please use the Q&A function, and if you're here in person, we'll bring a microphone around to you, so raise your hand if you have a question, and we'll get to as many of those questions as we can. For those of you who don't know much about us, the Center for Brain Health is a cognitive neuroscience research center at the University of Texas at Dallas. For the past 3 decades, we have been leading the scientific quest to measure and improve brain health across the lifespan. Because here's the bottom line: optimal brain performance is the new frontier for human potential. So I'd like to now introduce you to Dr. Hamid Ekhtiari. Dr. Ekhtiari got his MD at Tehran University of Medical Sciences in Iran, and his PhD in Tehran University of Medical Sciences. Also in Iran, he did postdoctoral work at the Laureate Institute for Brain Research in Tulsa, Oklahoma, and his residency at the University of Minnesota in Minneapolis, the U. And he did all that before assuming his position as the Division Chief of Addiction and Associate Professorship here at the Psychiatry Department at UT Southwestern University. He's also president-elect of the International Society for Addiction Medicine, and Division Chief of Addiction Psychiatry, I already mentioned that, and Scientific Director of Global Innovations and Addiction Research, ISAM. He's Editor-in-Chief of Progress in Brain Research, Associate Editor of the journal Addiction, and various other editorships and editorial board assignments. He has grant funding from the Dana Foundation and a Myron grant from the University of Minnesota. And with that, we'll listen to Dr. Ekhtiari's talk about brain oscillations and the addiction dilemma.
Thank you. Is me? Okay. Okay. This is okay. Hello, everyone. Okay, good. Okay. Very nice to be here, and thank you very much for the invitation. And many thanks to Dr. Chapman for the invitation. I've been following her works for many years, even when I was in the medical school. And I'm very delighted and honored to be here. Thank you very much for the invitation. And I'm very excited to be in this center that you are doing leading work in the field of brain health. And I'm gonna kind of discuss a little bit about potentials for developing new treatments for addiction, okay? Anybody in the room who has a family member, a friend, somebody that you know who are struggling or have been struggling with substance use, alcohol use disorder, things like that? Okay. You know that every year here in the US, we are losing close to 100,000 lives just to drug overdose. And these are beautiful minds, beautiful brains. Most of them are in their 20s, in their 30s. And that catastrophe happens every year. During last 2 years, the number is declining a little bit, but we are still losing some like 90,000 people per year only to drug overdose. And it's a huge problem. And those who have been involved in the process of treatment for one of their beloved ones, you know that the treatment, I mean, there are treatments, there is significant level of hope, but there are still limitations in terms of the things that we can do for those who are struggling with substance use, okay? So the idea is how we can learn more about brain and brain health to support people who are in the process of recovery and be able to do a better job in terms of their treatment, okay? So let me start with kind of not having a conflict of interest, kind of start thanking my colleagues and collaborators at the Laureate Institute for Brain Research, fantastic teams of friends, my kind of team of colleagues at the University of Minnesota, and my lab members who are involved in developing these sort of therapeutics. And I'm very excited to be here now. I mean, I'm in my 11th kind of week of being here in Dallas, so I'm still kind of learning how to navigate the city and how to drive in different highways and how to not to kind of kill myself in the highways. So that is kind of, but I'm also trying to develop my lab and also addiction psychiatry division here in UT Southwestern. I'm the division chief of addiction psychiatry here, and we just had the first division meeting yesterday. So I'm pushing it forward in terms of developing that service here and extending the resources that we have here. So we have fantastic group of clinicians here, but the challenge is how we can go beyond just providing the routine treatments and how we can develop further kind of innovative treatments for people with substance use disorder. We know that addiction is a brain disease, right? It happens in the brain. There are multiple things that are happening in the brain in the process of addiction. And we need to think about this brain and body disease, how we can address different aspects of that. And when we want to talk about addiction as a brain disease, it's important to be able to understand what is happening inside the brain, okay? When you are seeing a picture like this, what do you see? Somebody is cooking heroin. It might be disgusting, it might not be that much something that would attract your attention, but somebody who is using heroin or those who are struggling with substance use, they see different things in that picture. And if we just make another control picture that has the same sort of content in terms of you see hands here, there are hands there, there is an action, there are some tools there, and if we show these pictures and also show these pictures inside an MRI scanner and see how brain is behaving differently comparing these two sets of images inside the scanner, what can we see? So these are brain activations that you see those people who are struggling with substance use. They have these activations when they are seeing those drug-related cues compared to neutral cues. If I put you inside the scanner and show you those two sets of images, there is not that much of difference. So you will not see any of those colorful blobs in your brain. But those who are struggling, there are specific activation. And as you can see, something like 1/3 of their brain gets activated because of being exposed to those images, okay? And these are the brain circuits that derives their craving and also push them forward to use substances while they are losing everything in their lives, okay? And this is kind of what is happening in their brain. And now we are thinking, okay, how we can do an intervention, how we can change those brain activations in those circuits in a way that we can help them to stop using alcohol or other substances, okay? But to be able to understand those activations, I should say that there are specific circuits in the brain that when people are seeing drug-related images like this one, as you can see here, they get activated. One of those networks is called DMN. Have you heard about this network in the brain? It's default mode network, right? And activation in the network is involved with craving. And then there is another network called executive control network, okay? That network is mainly involved in being able to exert control over default mode network. So usually you have a balance between default mode network and executive control network. So when you have strong activation default mode network, executive control network usually goes down, as you can see here. And this is the state that people experience when they have craving. And there is a specific network, it's called SN network or saliency network, that basically keeps the balance between these networks. So this network decides that which one should get further activated. And it might be interesting that inside your brain, there is not enough space for blood for both of these networks. So you basically need to change the mode between them, whether you are in your default mode network mode or you are in executive control network mode. So that is the, and saliency network decides which one you want to be in. So this is a craving state. Even when you have significant craving for food, you will be in that state. And that is the reason that when you are in significant level of craving for food, it is hard for you to be focused and do an executive job. You feel that, oh, I have too much craving, I need to eat something before to be able to go back to do my executive tasks, okay? So when you feel lots of kind of craving to have your lunch, I mean, it starts hard to be focused and get things done, right? So that is the balance that we have. And if you go to another state, which we call it control state, then your executive control network is going to be more activated and you have further control on your behaviors, okay? So it is not only in substance use disorder, but in any aspects of control in your life, you can have this balance between executive control network and default mode network, okay? So that is the balance that we have. And the good thing about it is this, if we can modulate that, if we can have specific interventions to change one mode to the other, the person would be a totally different person. So the same person, but in different modes, okay? And this is what have you, I mean, if you work with people with substance use, they sit in front of you, they are like everybody else. They are functioning really well. But when they are in the craving state, they steal, they do lots of really bad things, and sometimes even their mom, they say, I mean, I cannot believe that this person was the son that I basically nurtured for his entire life, and now he's behaving like this because he goes to a specific mode that executive control network is not functioning anymore, okay? So we have different technologies that are developed during last 10, 20 years, some of them are a little bit older, that they provide us with a set of interventions that we call them circuit-based therapeutics. So we can target a specific circuit to be able to develop, to change the way that the brain is functioning. And I will discuss a little bit about some of those technologies today and see how we might be able to change the pattern of activations that these networks to be able to support people. One of those technologies is called what we call transcranial electrical and magnetic stimulation. So these technologies, we do not open the skull, we do every stimulation, everything from over the skull, and they are very non-invasive. I have done lots of those stimulations on my own brain. So this is something that and whenever I'm recommending an intervention to anybody, I'm definitely happy to do it on myself. So that is something that that's a part of my research ethics in terms of whatever intervention that people are going to receive in my lab, I should be the first person who is happy to receive those interventions, okay? And they are very safe. The level of energy that we put inside the brain is very limited, and there are multiple studies that are not harmful. And I'm very careful about my brain health. So I even control significantly a lot of caffeine that I receive every day. I mean, maybe maximum 50 milligram of caffeine in few days. But I mean, I'm really careful in terms of how I kind of manage my brain health. So, but meanwhile, I'm totally fine to receive that level of energy inside my brain because it's very minimal. And the number of studies in this field is just increasing over time. So there are lots of new studies in these fields. And there are some FDA approvals for using these technologies for treatments of different psychotic disorders right now. And I work in interventional psychiatry clinic in UT Southwestern, and we provide some of these treatments for people who are suffering, for example, from depression. There is an FDA approval using TMS for depression in 2008. And that is a routine thing that we do, and that is a very effective intervention. I have patients that they received Every single kind of medication that you can imagine, and they have not been responsive, and now they are very responsive to TMS. And it is phenomenal to see how it would be helpful for people who are suffering from depression. Anxious depression 2021, they extended the age of being able to use. Now we can use it even starting from age 15 up to age 86 because people realize it's a pretty safe intervention. And then there is a new line of protocols. Traditionally, even right now in my clinic, when we do TMS, it is 6 weeks, every day, 5 days per week. It's a 10-minute session. It's not that long, but you need to make a commitment for 6 weeks being in the treatment. Now there are accelerated protocols that we do all those things in 1 or 2 weeks, multiple sessions per day. And even there are studies that you can do it in 1 day, something like 20 sessions in 1 day. These are what we call accelerated protocols, and it seems that they are working reasonably well. And then there is another level of intervention that we do mapping. So we find a specific circuit in the brain using neuronavigation and target that specific circuit. And this has been approved in 2022 as a treatment for depression. There are interventions for OCD right now, 2018, a specific intervention for smoking cessation, 2020, but nothing else in other areas of substance use disorder. And our center and multiple other centers, we are running large-scale trials for meth, alcohol, cocaine, opioids, to develop new treatments. So you will hear new innovations in the field within the next 5-10 years. So there are lots of new hopes that we have within the trials that we have done recently. And it seems that it's going to be a new line of interventions in the field of substance use disorder as well. There is a new approval, December 2025, to use transcranial electrical stimulation for depression with a device that is a home-based device. And that's a very new, recent FDA approval. And these devices, these transcranial electrical devices, they are pretty inexpensive, a couple of $100s, and they can be home-based use. So we can even prescribe them, and patients can take them home, and they can use the technology in home. So there are lots of opportunities with these sort of inexpensive technologies that people can use. And today, my talk is going to be mainly focused with this specific technology for substance use disorder, while we are using other technology. We'll give you some few examples of other technologies as well. So when we have been discussing about those specific circuits in the brain, the question is, can we modulate this balance and change from craving state to control state, right? And how we can do the modulation. So as you can imagine, if I go back, the question is, what would be the right target? Where should I do the intervention? You have intervention that you can reduce the activation in the brain, and you have intervention that you can increase activation in the brain. Just look at this map and tell me what would be the best intervention to go from craving state to control state. Let me give you an example. For example, we have ventromedial prefrontal cortex that is too much activated when people are in default mode, in the craving mode, right? So if I can suppress that part of the brain and reduce activation in that part of the brain, there is a chance that I can dampen the default mode activation and support executive control network to get activated. Does it make sense? Okay? So this specific target, we recently published a paper in American Journal of Psychiatry that ended up to the cover of American Journal of Psychiatry, discussing about different interventions that we can target that specific ventromedial prefrontal cortex part with different transcranial electrical, magnetic stimulation, and finding the right target to be able to do it inside the brain. So that is one of the targets that we are working on right now. And we published multiple studies that how we can individualize that. Because one of the most important things about the brain is our brains are different. So my brain map has similarities with your brain map, but there are lots of differences as well. And we need to take into account those differences. And this is the fantastic things that you have in this center, because with all the things that you are able to do here, you can do the brain mapping part. You can see the differences between different people's brain, and you can use that data to optimize the way that you are targeting those networks. So we showed that we need to, for example, this is a study that we did for 60 people who have been using methamphetamine, and we showed that the right target for each of those people would be significantly different. So each of those dots is one single patient with methamphetamine use disorder, and we showed that there are different locations that we need to target to be able to get to that circuit, to be able to dampen that default mode network activation. Does it make sense? And we have different ways of optimizing the location, the orientation of the coil, and to be able to do it in the right way, we develop ways to be able to use robots. Because even the kind of the normal location with normal kind of people hands, it's just hard to manage that. But when you use robots, you can just be very precise and stay exactly on the area that you want to target. And even the subject, when subject moves, the robot also moves to be able to just make sure that we're still targeting that area in the brain. And this is another technology that, to my best understanding, nobody has in Dallas. And that is another thing that we have been discussing with Dr. Chapman in terms of how we can bring those technologies here to be able to advance circuit-based therapeutics. So that kind of target is definitely a very interesting target, but there are other targets to consider. And I will discuss a little bit about those other targets. So I really like that executive control network and how we can support that network, how we can increase function in that network. And it is important in addiction, but not only addiction. In many other areas, even in depression, one of the challenges is those who have depression, they do not have that much of executive control, that much of kind of focused attention to be able to find solutions for the problems that they have. They get stuck in something and they cannot just come out of that. And that is something that we can do if we can empower that executive control network, okay? So, and the idea is how we can activate the two major nodes of this network to be able to increase the activation in that network. To be able to do that, we are using a new technology to be able to use multiple array of electrodes over the cortex and deliver very limited amount of current inside the brain and engage those nodes. And if I want to show you, and I mean, Ashkan, one of the research assistants in my lab, kind of putting the electrodes. I've done that myself as well. I will show you the photos. But this is a more sort of technical picture of that in terms of putting the electrodes, the level of electricity that we put inside, something like 2 milliamps, a very, very limited amount of electricity that, I mean, even a simple battery can make that level of electricity. So it's very limited amount of electricity that we put inside the brain. But we showed that even that very little amount of electricity can entertain the way that neurons are firing inside the brain and orchestrate the way that they are firing in a way that they can work together. So that is the what we call high definition transcranial alternating current stimulation to do what we call frontoparietal synchronization. So we try to have these two nodes to oscillate together. And then when they oscillate together, they get connected to each other. It might be interesting that when two parts of your brain wants to get connected and transfer information between these two nodes, they need to oscillate in the same frequency. When they are in the same frequency, then they can talk to each other. Now they get connected. Now they function. Now they act as a network, okay? So we do it from the outside. So we help those nodes to get to that specific rhythm to be able to talk to each other, okay? It might be hard for us, when you are in control, you can just do the oscillation by your own free will. But when people are stuck and they cannot do that, we can just support them in terms of being able to do the oscillation. Something like a physical therapy. That somebody who cannot move their limbs, we can just do a little bit of supporting them to be able to move those things that are not functioning. One of the new studies that we just submitted in medRxiv, February 11th, 2026, it's a very new data that I'm going to show you about how that specific synchronization can function. A fantastic kind of postdoc in my lab, Ghazale. And most of the postdocs in my lab are from electrical engineering, from physics, from mathematics. I already have one of them here, RF, who is from the physics background. So, I mean, if you know brilliant people from the engineering side, just kind of introduce us to, I mean, we really like to work with people who are from, because we need lots of brilliant minds from the engineering side to be able to develop those technologies. So, this is a specific technology. That is the intervention. We do active and also sham. In sham, we do not do the intervention. We just make their skull to tingle a little bit without actually delivering current inside the brain. And we are controlling active and sham. This is a clinical trial. As you can imagine, the design, we divide people in two groups. And we recruited 60 people for this trial, 30 in each arms, and doing fMRI before and after to measure the effect of intervention. This is a Prisma kind of flow chart in terms of the consort diagram, the subject that we recruited. And the idea is, as I mentioned, when we target DLPFC and posterior parietal cortex, we activate these areas and they can kind of reduce the activation in subcortical areas that are a part of default mode network. Those parts of the kind of limbic cortex in kind of deep parts of your brain. Areas like ventral tegmental area, amygdala, striatum. And there are areas that are generating craving, generating negative emotions, things like that. Okay, we showed that when we do the activation on frontoparietal cortex, there is a significant reduction in activations in ventral tegmental area, amygdala, and striatum. And this is the whole brain activation maps. So we can activate those networks and reduce the activation deep in the brain. If we do network level analysis, we can show that this is the side that we have been doing that on the right side of frontoparietal cortex. And you can see that there is a significant connection between these nodes. And also interestingly, it can also even activate the other side of the brain. So because the brain is in a balance, when you do an intervention in one side, the other side usually gets involved. And also the blue lines show the top-down control from these control networks to subcortical areas, whether it's ventral striatum or amygdala. So we can reduce the activation in deep parts of the brain. So this is the way that these analytics are happening. And these are specifically, there are specific connectivities that we call task-based connectivity. And these are the connectivities that are related to when they are seeing the drug-related cues. So these are connectivities related to craving. And we can enhance the control part and decrease the activation deep part of the brain that is generating the craving. This is the level of craving that people have been reporting before fMRI. This is the baseline. This is before fMRI. This is after fMRI. In fMRI, FTCR is when we are exposing people to drug-related cues. fMRI, drug cue reactivity. We expose them to drug-related cues. And because of that, the level of craving goes up because we expose them to drug-related cues. But when we do the intervention, it goes down. The reduction in the level of craving when we do active is more than the other one. But it didn't make the amount of significance that we have been interested to have in the statistical part. So it seems that we are able to reduce the craving, but not exactly in the quality that we have been interested to have. So it seems that we still need to do some improvement in terms of the way that we are doing the intervention. But it might be interesting that the level of craving reduction that we had was correlated with the level of frontoparietal connectivity that we have been able to make. So the more frontoparietal connectivity that we have been making here, the higher the reduction in the craving part. The challenging part is we have not been successful in activating frontoparietal connectivity in some of the patients. Why? Because we have been doing one-size-fits-all approach. So we have been doing the same stimulation protocol, the same sites in the brain for everybody. So there was no individualization, there was no precision. So we have been recording the brain, but we have not been using the brain maps to inform the way that we have been putting the electrodes there, okay? We also showed that the level of electricity that we have been delivering in the frontal area would be related to level of frontoparietal connectivity changes. So the higher energy that we have been putting there, the higher connectivity. So that's a sort of a what we call dose response. So the higher dose, the better impact. So it seems that we are able to modulate that network. But sometimes finding the right network and doing that in the right way is not as easy as people might imagine, okay? So this is an offline setting. So we have been doing fMRI before and after. Now we start to think about, okay, if you want to do individualized version of that, if you want to optimize that per individual, we need to be able to not only record before and after, but do the stimulation while we are recording and see if we are doing the stimulation, is it really engaging the network? And if we can do that, how we can optimize that. If it is not engaging network, can we just change the stimulation to be able to improve the? So to be able to do that, we need to do what we call concurrent electrical stimulation fMRI. So we need to do, while we are showing people drug-related images, we need to do the stimulation. This is the stimulation. We need to do a stimulation inside the scanner. And it is a technically challenging task to be able to do because MRI machine is super sophisticated tool and adding anything inside that is very complex, okay? To be able to do that, we had a kind of a fantastic team of engineers, physicists in the University of Minnesota, and we developed a specific technology to be able to do it inside the scanner. And we realized that the number of people who are working in this area, the total number of scientists that are working in this area is very limited. So we decided to basically invite everybody who has tried to do it inside the scanner in a panel and asking them how we can do it in the best possible way, because it seems that there are very few labs that are able to do it. So we invited everybody who has been doing that around the world and develop a consortium to be able to bring our forces to make it happen inside the scanner. Because most of the labs who have been doing that, they failed to be able to do it. So we brought everybody together and we made a consortium and we put together a specific consensus statement in Nature Protocol, which is a kind of really high impact journal, showing that how we need to do it in the best possible way. And we use that specific pipeline to optimize the way that we have been doing that. And then, while we are able to do it inside the scanner, we started to realize that to be able to find the best way to oscillate and engage those networks, we need to find even the oscillation rate in each individual person. Because people have, sometimes they are a little bit faster, sometimes a little bit slower, and the way that different parts of the brain talk to each other is a little bit different. So brain oscillation is something like I have an accent, right? So, I mean, the way that I'm basically talking is unique to the way that I've been trained. English might sound like my third language. So, as you can imagine, based on that, I have a specific tone in my way. But you understand how I'm talking, but there is a difference, right? This is the way that our brain is also functioning. So the way that different parts of the brain are interacting is very much personalized. So we need to find, for this specific patient, what is the best frequency and what is the best phase of the brain oscillation that would be the way to engage that network. So finding the right target for that specific person, which is a very challenging task. So brain is a super complex machine, and just be able to fine-tune it, it is complex, okay? So to be able to do it, we develop a system we call closed-loop electrical stimulation and fMRI. So we have been able to do electrical stimulation inside the scanner. So we have been able to do it before. With that consortium, we put everybody together. Now we are able to do a stimulation inside the scanner. We also can record that network inside the scanner as well. Now we have started to put those pieces together and say, let's just record, do the stimulation, and then measure how much our stimulation was successful in terms of engaging that network, and then optimize the stimulation in the second round and do the stimulation again, and record again and see I've been successful or not, and then change it again. So do it multiple different times to find the right way to engage the network. And that is what we call closed-loop brain stimulation. To be able to do that, as you can imagine, we started to stimulate watermelons because it was hard to kind of start with human inside the scanner. So we started to develop the technology, different electrodes to be able to put it over watermelons, develop technology to be able to kind of make that happen. And also, now we are able to see inside watermelon in terms of it's a good watermelon, it's not a really good watermelon. So you can see from the outside. That's the best way to use fMRI, but you can see inside the scanner. You can see, I mean, it's a really good watermelon. So from the outside, you can see, okay. So you can record from the watermelon. And of course, after each stimulation, we just eat the watermelon. So we test the watermelon as well in terms of, okay, what was inside the images are really there or not. So that is the part of the team that we had together. And of course, after watermelon, who should go inside the scanner? Right? So they have been putting electrodes, and I was kind of the next person who has to go inside the scanner. So lots of fun with people around to be able to make those things happen. Fantastic postdocs, Aki and Benny. We have been able to make that setting happen in terms of putting all those pieces together. Be able to develop a specific electrodes going inside the scanner, optimizing that. And this is the first kind of technical report that we showed that we can actually do it inside the scanner. First, what we call online, closed-loop, real-time transcranial electrical stimulation with fMRI for brain modulation inside the scanner. I'm going to show you the very first trial that we have done in this field today. So this is the first trial that we designed to be able to do in a way to be able to do, first of all, a phase of training in terms of trying to find the best frequency and phase of a stimulation for each individual, and then doing a test run afterwards to see whether that specific frequency is working to be able to upregulate or downregulate the network, okay? A small trial, we recruited 23 people, 10 person in each group. This is a healthy control people, so it's not a clinical population, healthy control people. And the question was how we can engage that network to be able to increase working memory and executive function tasks. So it's a healthy control people to engage them in that process. Connectivity inside the brain, some kind of interesting things. First of all, this is the protocol to downregulate, and this is the protocol to upregulate. And as you can see here, we have been successful to some extent to upregulate individually, but we have been more successful in terms of downregulating the system, okay? And this is the space, and each of those dots are one individual in terms of the individual frequency and phase of the stimulation for those people who have been inside the scanner. This is the behavioral results. We measured accuracy and also reaction time. As you can see here, in the upregulation group, we have been successful to kind of increase accuracy a little bit, as you can see here. And in terms of the reaction time, we have been able to reduce the reaction time further in the upregulation group compared to downregulation group. In terms of the brain activation, this is the brain activation that we have in the upregulation group. As you can see here, we have been able to upregulate that frontoparietal network and downregulate areas that were related to default mode network in terms of being able to engage the network. So we have been able to engage the network. So you can tell me, I mean, that is a pretty expensive intervention because you need to put people inside the scanner for something like a 30, 40 minutes, find the right kind of parameter for that specific person. And if you want to do it something like a 10 sessions of intervention, 20 sessions of treatment is going to be very costly, right? So the way that we are looking into in this specific pipeline is, okay, we do one session and we find the individualized parameter. And the next time, we do not need to do it inside the scanner. We can just use the technology I told you is going to be something like a couple of $100 outside the scanner and do multiple sessions outside the scanner. Because we know that when we do multiple sessions, it's something like a physical exercise. It's like any sort of brain exercise. You need to have multiple sessions to be able to get there, but you do not need the scanner anymore. So you use that specific way of a stimulation outside the scanner. Or there is another way that we are envisioning to use in the future. When you find the right way to engage those networks, you can just use it, what we call just-in-time use of the intervention. How? It is 3 a.m. in the morning. Your patient has a significant level of craving for heroin. They really don't know whether the heroin has fentanyl inside or not. If they use it, nobody is around. If they use it, they can overdose, and nobody is around to support. And there is no sponsor that they can call, or there is no medical support to support them. They can put the electrodes over their head. We already have the home-based devices, and just turn on the machine, reduce the craving. And if you can reduce the craving for 5-10 minutes, you can save lives. And that is the way that we are thinking in terms of finding the way to engage that network and then giving people the device that they can use at home in the future when they are facing those challenges in their lives. And this is a pipeline that we are developing and extending right now. Okay, so wrapping up, we discussed about neuromodulation and precision neuromodulation and how we can use these technologies in an individualized way. There are multiple different studies that we are doing. I just gave you one single kind of shot of what we are doing, but one of the most updated results that I haven't presented there, I mean, those results anywhere so far, so it's a kind of first time that we are presenting those results. And the hope that we have, we are already discussing that with Dr. Chapman. We started to discuss that with Dr. Impa and kind of Bart in terms of how we can kind of collaborate together to be able to use these technologies in the center that you have here in collaboration between UT Southwestern and UT Dallas here to be able to make those things happen here. The closed loop one and also the robotic part. So these are the two technologies that we are hopeful to be able to have in this center. Maybe in 2-3 years we can discuss about the results that we have in this center. But meanwhile, it's also always important to also educate patients about what we are actually doing. Because sometimes when you talk about brain stimulation, it gets very scary for people, right? So they say, I mean, I'm not going to give my brain to you to do this stimulation over my brain. So people get scared about what you are doing. So it's important to give people understanding that whatever we are doing and discussing, how they are functioning inside your brain. So we develop different materials about brain awareness in the process. They are now in 22 different languages. Now we are developing specific new materials about using those technologies, brain stimulation technologies, and how these specific brain stimulation technologies are actually helping the brain in the process of recovery, and how they can support, while, some other interventions are not enough. So we can do further support with those interventions. Those who are interested, we have every 2 years, we invite the most brilliant minds in the field to a meeting in New York City, and we discuss about different technologies for addiction treatment. That is the next meeting that we'll have in July 30th in New York City. And those who are interested to learn about these technologies, I have an online course. It is free. If you scan the QR code, you can just take the course. And if somebody is interested to have my slides, just send me an email. It's just my name, family name, UT Southwestern. I'm happy to send you the slides and all the education materials that we have. So those who are interested to learn those kind of technologies, we are training residents, psychiatrists, new generation of kind of treatment providers to be able to provide these interventions. And the last slide. So let's think for a minute at the end what we learned today. Ten major things that we learned today. Should I kind of, who's a volunteer to say one note that they learned today?
I came up in '75 and we were doing, I've learned just how advanced neuroscience has become from ECT therapy and glass electrode insertion.
There's more to learn about the differences in frequencies you were talking about within the brains. I'm curious about that, and at least you want to read more on that. So what effect that has on the research.
Okay, fantastic.
I'm excited to learn about the affordable home devices.
Home-based use, yes, that's the technology. Do you want to, just think about one thing that you learned from the discussions today, or one insight, or one kind of curiosity that you started to think about, specific thing that you are interested to learn more about.
So maybe we could use this brain stimulation for obesity.
Absolutely,
to
absolutely.
To reduce the cravings.
Absolutely. So the craving is not just substance use. Even there are some addictive behaviors, those who have gambling disorder, all those things that could be another opportunities. Who else is going to go? Who else? Yeah.
I'm curious on what the numbers look like as to what addiction costs the economy versus what this treatment costs, as far as the comparison of how much we would be saving, not necessarily because that's something that would matter to me, but I know that in selling such treatment to get funding or support, that's something that can be attractive to them.
What is the value if we can develop a technology here within the next 5 years that from those 90,000 people that are dying from just opioid overdose, we can just save 1,000 lives every year? What is the value of that?
Measured how?
Can we put a number in terms of the dollar value of kind of saving 1,000 lives every year? Right? So it is, and the problem is huge. It's huge. So if we can do even one small kind of impact, that is going to be huge. Please.
Thank you for this wonderful talk. It was really fascinating. The thing that I started thinking about with the combinatorial therapy would be, I know vagal nerve stimulation has been used to reduce drug cue salience during extinction training. Have you guys thought at all, or I got thinking about combinatorial therapy with TMS and vagal nerve stimulation.
Yeah, that is definitely another really interesting avenue, especially with the In my clinic, we use two types of vagal nerve stimulation. The one that we are mainly using right now is the surgical one that we put a little bit of electrodes around vagal nerve. And those who, especially those who have lots of ups and downs in their emotions, some day they are very happy, they're not really functioning well. So we can just reduce that level of ups and downs in their lives. That is what we use right now as sort of surgical way of doing that. But now there are multiple companies that they are putting small electrodes in your kind of around the auricles, and they can modulate specific parts of vagal nerve that are in your kind of around the ear lobules, and they can modulate that. That is that there are, and interestingly, one of those companies, the CEO is based in Dallas. So they're Spark Biomedical. So they are doing a fantastic job, and they already started to doing great job for opioid withdrawal, for some of the kind of emotional issues. So, I mean, there are definitely opportunities in terms of even modulating the brain from the outside, because those, it might be interesting that the vagal nerve and some of the peripheral nerves, not only they bring information from the brain, but also they take information to the brain as well. So there could be pathways towards. So instead of just doing the stimulation over the brain, we can do the peripheral to get inside the brain. Yep.
So Hamid, there's a question coming in from our online audience. If the interventions for drug addiction can be done, has there been any effort to try these methods for excessive screen time, excessive scrolling, internet use,
So I
social
think
media?
we are definitely facing many behavioral addictions that we have not been thinking that is going to happen to us. Everybody was thinking, okay, I mean, the screen time using kind of cell phones, smartphones, social media, we always have the control. But now we are actually seeing people in the clinic that they are significantly struggling. People who say that I'm driving the highway and I'm still scrolling inside my phone, just seeing the videos, and I just put it away for a few minutes, but I just need to go back, and I'm driving 80 miles per hour in the highway. You probably have seen some of those people in the highway, right? So, and they are a threat for their own lives and also others. I mean, the number is just increasing. World Health Organization, just kind of a year ago, they realized they need to kind of consider that as a kind of an emergency. It's going to kind of emerge as a really big public health issue. So they put together a commission for Lancet Psychiatry, which is one of the top-ranked journals in psychiatry, to discuss about problematic use of the internet as a new mental health disorder. And I'm one of the kind of members of the steering committee of that kind of group. So we discuss about what is really happening. And even the way that companies are developing technologies that are addictive, right? So and even now with AI, they can even individually optimize that for your own brain to be able to get you further and further engaged, right? And I mean, this is going to be another kind of epidemic of challenges with addictive behavior. So addictive behavior is just beyond the substances. There are many aspects of addictive behaviors that we can consider and we should consider. And that's a part of even the treatment services that UT Southwestern provides in terms of the not only substances, but different sort of addictive behavior. And everybody is vulnerable. I mean, and especially kids. Just, yeah.
One of my take-home notes was how we'll need to increase the definition of addiction to include children and include, I think that you would save more lives, maybe not in the same way, from addiction of drugs to the depressive and the emotional kinds of addictions.
Absolutely. And those things are highly linked to each other. I mean, depression, addiction, trauma, all those things are highly interacting. Please.
One of your slides had DBS, deep brain stimulation on it. And I wondered, some of these at-home treatments, very appealing to patients, but for folks who are really suffering intractable addiction problems, what promise do some of those more invasive treatments have for people that, so that maybe they don't even have an urge to begin with, to have devices essentially implanted invasively?
Absolutely, absolutely. That's a really good question. We have patients in the clinic that they have alcohol use disorder, okay? And they have been in treatment multiple times, they failed, they tried different medications. Now their cirrhosis, their liver damage is just progressing. And they are in a trajectory that in 1 or 2 years, they would end up to cirrhosis in a quality that they need a liver transplant or they will die. And you know, liver transplant is probably the most complicated surgery that somebody can go through. I'm not sure, have you been in that process? In my medical school, I've seen those surgeries. It's just one of the most complex surgeries you can imagine. It's just something like 12 hours of surgery to remove the kind of the cirrhotic liver out, putting another liver inside, all those kind of arteries and kind of veins that they need to graft again. It's just unbelievably the most complex sort of transplant surgery that you can imagine. And that is the only thing that people can do. And it costs millions of dollars. It's just super complex process. And they know that it's going to happen, but they cannot stop drinking. And you need to shut down that center, right? So there are different technologies. DBS is something that we have been considering. When I was in University of Minnesota, we had a collaboration with Mayo Clinic working in terms of how we can kind of find the right circuit. There are already few very small scale trials that people have started to do that. There might be interesting that in Clemens Hospital, there is a team of people who are working on a technology that they can use ultrasound to do some kind of modulation inside the brain, and they are using that specifically for those who have tremor. And they can find the pathway that is making people to have tremor, and they can modulate that. And they are doing a really nice job. I actually visited their center just 3 days ago, and we have been discussing about using that technology for those who are suffering from significant level of kind of alcohol use and addiction. The challenging part is, even if you want to use that technology, we need to have a really, really good brain mapping and finding the right thing to do it. And that is another thing I was discussing with Dr. Chapman in terms of, I mean, you have a fantastic brain mapping center, and you can use it to be able to develop that level of precision to be able to find those areas. And even when you are not going to do the deep brain stimulation here, you can still do the mapping and then guide us, and we can use those maps in a clinical environment inside the hospital and go inside and do the intervention. But we need to have that quality map. And sometimes, because, I mean, in the hospital we have something like 10 MRI scanners, but they are all super busy. So you cannot say, okay, I'm going to book the scanner for a day to just put the watermelon inside the scanner and look in. I mean, it is crazy. They cannot do that. But here, because you have those resources and the technology and experts in the field, so you can kind of expand the horizons of science for that, and then we can use it in the future for the interventions.
So my question, I mean, brilliant talk, oh my goodness, and your leadership in this field, we're so lucky to have you in Dallas and Texas and lead the way. My question is, and maybe challenge to you, is you're showing the change in the frontal parietal, and that's a key area. It's also one of the areas that we target with our cognitive training, and we show very significant improvement in it when they do it. So what if you kind of did the TMS to get the brain ready, and then to have more lasting effects, we partnered so that we could do the cognitive training that the people could continue building it.
Absolutely. And that is exactly the frontiers of the field in terms of, yes, brain stimulation is helpful to boost up the process of recovery, but you need to, it's not like exactly like physical rehabilitation. Those who have been doing PT, OT, you know, I mean, the most important part is just the physical activity that you need to do, but there are some devices that they can kind of put a little bit of heat inside your muscle, do a little bit of, and you need to take some medication. So those things would facilitate. But at the end of the day, I'm a true believer of cognitive interventions. And I'm a true believer of cognitive empowering. So eventually, at the end of the day, that is going to be the brain gym and brain exercise that is going to make a long-lasting effect. But there are sometimes needs for some initial kind of support to be able to get out of that sort of hole that they are there, to be able to now they can start to, when they get to a level that they can now do the physical exercise, then so that is the reason that I'm here, because we need to work together. So, I mean, I have my own startup money, I have kind of the other things in UT Southwestern, but I mean, I need to have support from Dr. Chapman because of her expertise, because we need to work together. We will not be able to do it just from one team. I can say, okay, I'm very successful in terms of just bringing people a little bit out of that, but what is going to be next? We need to put our kind of resources together to be able to have the full spectrum of the interventions that we need and holistic view of doing that. Otherwise, we fail, and we cannot be very successful in long term.
Hamid, Sandy's blushing over here. I just want you to know. So, big round of applause for Dr. Ekhtiari. That was a fantastic talk. Lifelong brain health. This is our shared mission. Thanks again to our speaker. One more round. Yes. Okay, two final points. Join us for Brain Health Week during the last week of February. Please scan the QR code to see all the events and activities and sign up. We hope to see you again next Friday when we hear from Dr. Pooja Parekh, Assistant Professor in the Department of Neuroscience at UT Dallas, talking about neurosubstrates underlying effortful behavior in animal models.